Hi, I'm from the future. The year is 2036. The time is 9 a.m. I'm sitting on the beach in Hawaii and operating on a patient in LA, Los Angeles, in 3D vision by remote control using robotics. Just kidding. But I'm going to show you today the advent of new technology where instead of looking through the microscope, we are using 3D technology to see everything on a screen. And this is going to be the wave of future as computers and microprocessors increase in speed, which will in fact make it possible for us people in developed countries to operate on the underprivileged in developing countries without actually going there. With the advent of COVID and other things, this becomes a much needed reality. So without much ado, we're going to do a demo on the Carl Zeiss 3D system. And we're going to start from the beginning. This is the eye. We're making some orientation marks, which helps us in aligning a toric intraoctal implant. We've previously made and now we're reinforcing the marks at 3 and 9 o'clock, which will help us to align the toric marker. As you can see, the lashes have been well draped by using plastic segments, and a speculum has been inserted. Now we are checking our axis, and the 3D system lets us know where our incisions should be, which we've calculated, and where our final alignment of the toric lens will be. That's the white line. And the beauty of the system is these alignments are deployed throughout the surgery, so you're very aware where you're working, where you can make the other wounds of entry. And the yellow line is our line of reference along the two marks we made, and the white line is where the lens will sit finally in that position. Now we are making our parasynthesis. These side ports, which are highlighted in teal triangles, are where we insert fluid and medicines. And our main wound, where you see little heme, is at 200 degrees and it's measured at 2.4, but usually we use 2.2. Now it's indicating what would be those rings in purple are our capsular excess size. Inner border is 5 millimeter, outer is 5.5. So I like to go in that zone and make it very strong. You'll be surprised to know the manual capsular excess is stronger than the one generated by the laser, because laser is by multiple pock marks, whereas manually done is a continuous curvilinear, and so there's no points of weaknesses. We like to inject something called sugar cane, which numbs the eye, and following that we are injecting a viscoelastic, which will coat the endothelium or inner part of the cornea, preserving it for the rest of the surgery. It also helps to deepen the chamber and stabilize, so when we start the rexes and complete the rexes, there's no upthrust in the eye, which can be pretty damaging and challenging. So first I'm using a sandwich technique. First was the cohesive and now the dispersive. Viscoelastic, two basically different ones, because the cohesive, the sticky one will coat the endothelium and protect, and this thick one will hold the space better and keep the anterior capsule depressed down so it does not go waywardly when we start moving it around. Good surface is necessary. As you can see, some oily residues are there on the cornea, which we remove by be a balanced salt solution flushing and removing from the cornea, so our optics become better and we can see very good. This is a very good instrument. It's called a cystitome, but it's shaped, the angle and all have taken years of research, so it doesn't hit the cornea and is ergonomically friendly to put in, do its job, and come out. So we are not using this for more than 10 seconds. It just begins our rhexis, and then we take it out, and then we use a robotic instrument from MST. It's a capsulorhexis robotic forceps, which can go through small wound and open inside. And that's what's going to happen 10-15 years from now, where everything can be controlled by robots and surgery could be made more predictable, more universally available, and these are the foundations of the future. So we are very carefully curving our opening in the capsule, in the lens. And remember, we are not doing RLE or refractive lens exchange like it was done in the past. We don't remove the entire lens. We make an opening in the front and remove or vacuum out all the contents, then put the new implant inside. And then 3 to 6 months later, or even a few years later, we make a matching opening with laser on the back of the eye so that the light can pass uninterrupted through the lens. But the original periphery of the lens, including how it's attached to the eye, is retained. That's why the new implant can sit. If the entire lens was removed, then there would be no place for the lens to sit comfortably. That's why we call the procedure PI, or presbyopic implant in eye, rather than the old-fashioned RLE, which is a misnomer now, separating the lens capsule from the contents. So since we're only interested in removing the contents, we want to separate it from the rest of the apparatus, rotate it to make sure there's no adhesions or attachments which can harm the surgery. And now we bring in the sound machine. This is sound oscillating in front and back and torsionally, which helps to dissolve the lens into emulsified, almost like a paste, so it can be sucked out. This is all, as you see, done through a very small opening which will not require any suturing and is pretty stable. And we have to be careful, and as again I keep saying to everybody, we have to preserve the lens. Now we bring in the chopper, that's our second instrument, and between the two instruments we start breaking, cracking the nucleus of the lens. So the right hand engages and the left hand cleaves. We have to be careful not to go too far in the periphery and to remain within the lens and not grab the capsule by mistake, which will be disastrous. At all stages, double checking is better than trying to speed like in a racing car. Now we are rotating, gradually sucking out, and remember the patient is awake, alert, and talking to us during this, so focus has to be on being gentle, not causing any pain, as at the same time being efficient. Efficiency is more important than being fast. Efficiency prevents us from just sitting around doing nothing and exposing the eye to the elements, we have to hydrate the cornea frequently so that the image is good. As you can see, the rhexis is still being shown on the cornea, which is also helping us in the surgery, so we know we have to remain with this zone. So one of the great teaching points we learned and we teach is not to go fishing in the periphery in the lens, because the lens is thickest in the center and becomes thinner in the periphery. So if you remain in the thickest part, you're safer. Once you start going in the periphery, damage can occur if suction increases. Now we bring in some transformer. This is another piece of genius invention, which can go from a unimanual to a bimanual technique. Right now we are deploying the unimanual, and the tip is made from special material, polyamide, so it does not grab the anterior or posterior capsule easily. That was the biggest problem with previous cortical removal. They were either having metal tape, which could be sharp and damage, or they would grab the posterior capsule and cause tears. So the further along we have come in 30 years since I've been operating on cataracts, the safer, the more precise, and better the outcomes. We like to remove all the cortex. Now is switching to a bimanual technique. The advantage of this is subincisional cortex, which cannot be got with unimanual technique, can be still removed with bimanual technique. And we can switch between the left hand and right hand what each one holds, because we've got two side wound openings, so that way we can reach anywhere in the cornea, in the lens. So we see when the cataract is not advanced very much, there is a lot of stickiness to the fibers. Now we're removing the last, and we have to be very careful at that stage because there's nothing between that and the posterior capsule. You do see some discharge on the cornea interfering, but it's not bothering us. We were polishing the cells out. See, when you remove the discharge. Now we'll put in the jelly. Remember the beginning of the case when we were about to do rexes, we put in special jelly to coat the endothelium as well as create space. That's the same thing. We're going to put it inside the bag, inside the natural lens. And we have not removed the natural lens. We removed the contents. Now we've got an empty bag. It's like a suitcase now, which we have opened the lid, and we're going to put the contents inside, except we don't close the lid in this case. The lens is pretty big, but we fold it, and then this is known as patient-assisted implantation, because when we are putting it, I'm asking the patient to look towards me, and that force generated by me pushing and them looking allows us to ease the lens inside the eye and finally inside the bag. Now our alignment marks are going to be very useful so that we can position it accurately, and we will double check everything both with the advanced technique and with the previous techniques. Some part of the reason we're rotating it so many times is also to clean some of the cells which are not seen but are stuck on the anterior capsule, to prevent them from generating new fibers. Now the yellow line is guiding us to the alignment, and the blue lines, triple blue lines, are for the axis. So this special lens has sticky haptics, so once in position it does not rotate, it gets stuck. So it looks like our alignment is what we are looking for. The yellows are on the original marks, blue is where it's supposed to be at 16 degrees, as you can see. And you can see the axis toric marks. Now we're going to remove the viscoelastic jelly. We don't want to leave it in the eye because it's very thick. It can go into the trabecular meshwork and clog it, leading to high pressure. And that's one of the no-nos of doing presbyopic implant surgery. We can't afford high pressure because that causes pain and can damage the optic nerve fibers. We do give our cell phone numbers to patients if they have pain, which is unlikely, but if they ever have pain, which is very severe, we need to see them right away. The reason we are more concerned about nowadays about increased pressure is because the wounds are watertight. What that means is we don't allow any entry of fluid into the eye or outside the eye, which prevents infections. But at the same time, if we leave viscoelastic in a watertight wound and patient has predisposition to glaucoma, the pressure can rise. So now we are hydrating the wound to make them watertight, and then we'll test them with Vexel and depression to make sure nothing comes out. I'd also do manual check. Remember, I started doing it 30 years ago when we didn't have all the modern gadgets. So we used to measure pressure of the eye with our fingers. We used to call it digital tonometry. Now digital means different. But I think bringing all decades of experience to improve the outcome is a good set of qualities. In the final, moving the lens, checking the pressure, because we want to make sure any depression does not move the lens. So a little bit extra we are checking, because the lens is going to sit there for life. And so we want to make sure it's stable, it does not move with little pressure, especially because it's toric. If it moves, then it can change the outcome. Remove the speculum and we are all done. So all this was done without using a microscope, but seeing the surgery on the screen, wearing special glasses. And if you want to learn more about this, feel free to ask. Have a wonderful